So now talking about a little bit the treatment. So yes. What do you usually do? You use more exercise, you use a lot of manual therapy, you combine both. I know it depends on the patient, but like what do you think it's the most common approach needed?
So yeah, it's so easy. The easy answer to say depends, right? And that's physical therapists are beautiful at saying depends, right? So teaching students, they're like, oh my gosh, just please tell me the answer. Don't say depends, right? So, but with that, yes, yes, there's a time to be hands-on manual, and I have a manual background, and then there's a time to use that, and then there's a time to get away from it. Honestly, because I think a lot of current evidence doesn't support the long-term use of manual therapy for long-term outcomes and goals, because you must promote independence. And if you're going to promote independence, then you have to move eventually away from a heavy manual therapy basis, especially for someone who's trying to work on resilience of tissue. I say resilience of tissue, it means bone and tendon and muscle. And all of those need load. And you need to be there goes my light again. But that also needs to be like, you need to understand on a cellular level how you can improve the tissue of bone, muscle, and tendon and joints. And through my years of experience, people always ask me about like, Chris, where do you get your exercises? Or like, what are you doing different from exercises? And it's like, I don't pull my exercises off of the Instagram where you're trying to see the sexy approach to these really hard things that most people have no business doing. I've entered back into the true strength and conditioning world, where you learn the basics of true strength and conditioning. And that's really where somebody should be moving from physical therapy exercises, where you get away from bands, where you get away from off the table, and you truly learn how do you load tissue? How do you impact bone to make it actually heal 74% faster for an osteopenic bone in 16 weeks versus not 74% faster, how most people are treated from a stress fracture or something, versus how do you know how to appropriately load a tendon for a tendinopathy and tendinitis and keep somebody running versus being sidelined in a boot for 12 weeks. So I have to move away from hands-on manual therapy, which I do to a certain degree, and I'll do soft tissue work, joint mobilizations. I'll do repeated motions. I'm a McKinsey-based therapist. I'm also a Mulligan-based therapist. I'm a Maitland-trained therapist. So I pull from all of those to see how do I get my best results for who's in front of me. Do I use dry needling? I use dry needling a lot too. Again, a better mousetrap to maybe get a quicker and better result, so I can get the person up and treat them actually how to weight lift. How do they squat? How do they hinge? How do they carry? Can they do a clean step up? And then how often should they do that? And I'm trying to become very good at dosing, meaning how often should somebody truly do an exercise? Okay, because it's difference between you give somebody 3 sets of 10 versus 4 sets of 6. And you teach that person how to exercise twice a day, 3 days a week versus every day versus every other day. And so that's what I try to utilize, a lot of knowledge base of knowing what are you working on, what are your goals, and do you understand the tissue that you're working on from a cellular level and where the person comes from to know how to make that exercise better. I don't teach people how to do anything different than maybe another traditional therapist does or a strength coach. I try to combine them. So I do a lot of weightlifting and training with my patients. And many physical therapists, unfortunately, don't have the opportunity to have a weight heavier than 30 pounds in their clinic. But most of my clinics, I'm going to be teaching somebody how to squat or deadlift or carry upwards of 90 pounds or 100 pounds. Because that's what the body needs. When somebody runs, when you make impact to the ground, you're at least loading your body 2.5 times your body weight with every single landing phase. So eventually, a clamshell or a sideline leg raise on a table is not going to do it. You're going to have to train that person under some serious load and know how to dose that person appropriately so that way they can meet their goal.
Yeah, I think that's I'm so glad to hear all of that, because that's very different from what you're used to from the traditional physical therapy. And I come from some sports medicine background as well, that we were able, when I was in college, we had this project that we just saw athletes every day, and we were able to take them to like a soccer field and and play and test and shoot some balls and run and jump and carry weights. Would take them to the gym. So we did like until the end, like the real, like as you said, make them like functional and prepared to perform as much as they can, and develop all of that. That I think it is a missing part on the clinics, I believe, because we have some weights, but we don't have the space, we don't have the time, and many times we don't have the equipment to do that. So I think
unfortunately now.
Yeah. So that makes the difference on the last 20% that you said, that we have to, finalize the treatment. So I think that's very interesting, and I think that's a great work that you're doing, and I'm happy to hear someone is doing that, because it's very needed, right? It's much needed, and I think most places don't have this.